Pediatric AKI. To chair the session, may I invite Dr. Shubhankar Sarkar. He is Assistant Professor in the Department of Pediatrics and Pediatric Nephrology in AIIMS Kalyani, and also Dr. Deepshikha Baranwal. She is Consultant Pediatrician and Pediatric Nephrologist in Global Era Hospital in Dehradun. And our eminent speaker for this session is Dr. Anil Vasudevan sir. He is Professor in the Department of Pediatric Nephrology and Division of Molecular Medicine in St. John's Medical College and Hospital. Over to you, sir.
Check. Hello.
Okay, so good morning. We are going to start the first session. So we have a Professor Anil Vasudevan sir. I think no need any introduction. He is very well known among pediatrician and pediatric nephrologists all over India and abroad. He is a professor and in charge HOD from St. John's Medical College, Bangalore. His interest mainly on nephrotic syndrome, nephrogenetics, but today he is going to speak on AKI epidemiology and definition. Sir, please start your.
Thank you, Shubhankar, and thank you again, Rajiv, Deblin, and the entire team for your kind invite. We indeed had a very long session, but I must say that that violin event, what followed, was quite a refreshing thing that helped us, cope with that long day. So hope all of you had a good rest, and we start this today's CME theme on AKI. As you all know, AKI is more like a syndrome than a very specific disease entity, because it's a very heterogeneous condition. And I'm going to take you through the evolution of the diagnosis and staging so that we understand how the current criteria that we're using, and also bring in the limitations and nuances that we need to understand when we are employing these criteria, and finally how the standardization and recalibration of these criteria over the years has given us a better idea of the burden of this disease, of this syndrome. So much before acute kidney injury, the various terms used right from the late 16th century, including by Bywaters, who used the term war nephritis because of the increased amount of AKI they saw following crush injuries. And then the most popular term was acute renal failure. So what is acute kidney injury? I mean, conceptually, it is an abrupt loss of renal function and measured by the decline in GFR, and that results in the loss of the kidney's ability to regulate the homeostasis, particularly the fluid and electrolytes, and accumulation of the metabolic waste products. But a lot of these, how abrupt, how much decline in GFR, what kind of a dysregulation, all that was pretty decentralized in terms of the duration, the severity, and so on. So if you see, it is called I call it as a pre 20th century and the post. Before 2004, when the first standardized criteria came up, there were more than 35 definitions that existed to define the ARF or AKI. It was in 2004 the first that the Acute Dialysis Quality Initiative introduced the rifle staging for they still called it as acute renal failure, by the way. It was only few months later that the term AKI was proposed. And that is basically to make it more inclusive, because we all know it's a spectrum of injury where you could be completely asymptomatic only by the creatinine measurement in the blood, it comes up. And also that negative connotation that it's a failure. I mean, there's no hope of recovery. That perception they wanted to remove and create a window of potential responsiveness for early therapeutic and preventive interventions. Because of the limitations, I'll go through each of these individual later on. Because of the limitations in the rifle criteria, they came up with the acute kidney injury network came up with their classification of AKI. And in the same year, the rifle, because of its limitation to use in children, Zapitelli and his group had a modified version of the rifle called the pediatric rifle, which they validated in their cohort. And then because there now again it was going back to multiple definitions, the KDIGO unified these definitions in 2012. And after that, there has been not much change in these criteria broadly, but there has been some finer refinements by acute dialysis quality initiatives and KDIGO over the years. And in 2018, a Chinese group, brought up what is called a reference change value optimized for AKI to account for the biological variability of creatinine in humans. But this is not a validated concept, but I just wanted to put it up so that it kind of addresses one of the limitations of using these existing criteria. So let's go to the first one, the rifle criteria. The acronym, as you know, it stands here. Risk, injury, failure, loss, and end-stage kidney disease. It was basically a GFR criteria, but also had some relative change of serum creatinine added to it. And as the GFR worsened, the severity of the kidney injury worsened. And they also had a urine output criteria defined by oliguria of at least 6 hours. And as the duration and the severity progresses, the severity of AKI progresses. Now, one of the challenge of using this in the pediatric was that creatinine is very dependent on the age and the muscle mass and the growth and development. So Zapatelli, Stuart Goldstein et al., what they did was they removed this relative change and only used the estimated creatinine clearance of almost similar 25, 50, and 75, and validated this in an independent cohort and found it to be fairly robust. The urine output also, they changed the duration. I'm not sure of the rationale, but they changed the duration of oliguria that needed to exist as compared to the original criteria. And for this, they used the Schwartz formula, and the baseline of 120 ml per minute, if you don't have a baseline creatinine, was used for this validation. But nevertheless, one of the fundamental challenge with using this definition was that unlike in CKD, there is a dynamic changes that are happening of GFR, which may not be reflected completely in serum creatinine trends, unlike in CKD, where there's some kind of an equilibrium that is achieved. So for an example from a simulation from the same paper, as you can see here, this is in a situation simulation of a CKD where the GFR is around 60 and the serum creatinine is around 1.5. When there's an acute drop, you can see that there's a lag in the increase in serum creatinine. So it does not always, the GFR and the serum creatinine does not correlate and may lead to misclassification. This was one of the fundamental drawback of this criteria. The second drawback was that they used two outcome measures, that is loss of AKD, persistent kidney dysfunction, and end-stage kidney disease as one of the severities, which are actually outcome measures. Because of these limitations came the next, and also, I'm just giving you an example. So in children, if you have a change of, and it does not always correlate. For example, in a child who has a serum creatinine to begin with of 0.57, moves up, you see the calculated GFR. The corresponding rise of creatinine does not correlate with the fall of GFRs. Because of these limitations, a few years later, Acute Kidney Injury Network came up with a criteria, and an important difference was they defined that abruptness, that is within 48 hours, the change in the reduction in kidney function. And they removed the GFR-based severity stratification. And they also found in a large database study that even a small change of 0.3 milligram absolute change from the baseline was predicted independently the mortality and morbidity. And they used as this first change or a criteria to define or diagnose AKI. The urine output, they more or less retained that what was there in the rifle criteria. So now that there are two criteria, the KidGo came up with their what is called the KidGo criteria, which continues to be used as of now, which combine both of these. In the sense that the absolute change was maintained, but what they did was the absolute change is within 48 hours, while the relative change was over 7 days. That is the difference. That is, the AKI can happen anywhere between 48 hours to 7 days of the change from the baseline creatinine. They also brought in back a GFR element in the stage 3, especially in those who are less than 18 years. So they try to harmonize these two definitions, so all uses a single criteria. Now, any child who or an adult who needs renal replacement therapy, they automatically falls into a stage 3 AKI. And they also subsequently, many years later, came up with those who do not recover completely, the term called acute kidney disease, and they defined it as those having persistent kidney damage, which does not meet the criteria for CKD, that is 3 months. So the challenge in children remained as how to use this definition in neonates, because we know that they have their physiology of the kidney function is developing. So does it hold? But whatever was that was proposed, was almost the same as in the KDIGO criteria, the absolute change of creatinine and the relative change of creatinine. But there was a suggestion that the urine output, because they are invariably a non-oliguric AKI, that urine output should be a little more liberal, that is 1.5 ml per kg per hour, and the duration of that oliguria should be a little longer. That is because they wait for that kidney to kickstart its function. So these were the fundamental changes that were proposed specifically for the neonatal criteria. So in a nutshell, these are the criteria that exists today, and these two have been superseded by the KDIGO criteria. But they have its relevance in different contexts. So now, just because it is harmonized, is this criteria better than Rifle or Ekin criteria? I mean, there have been few studies looking at comparing these three criteria. One of the largest, I will only quote, is the hospital EMR-based database study that included close to 15,000 admissions over a period of 4 years. They did find that the incidence and the stages of AKI differed. That is, the P-Rifle picking up more number of AKI as compared to Ekin and KDIGO. However, irrespective of the criteria that you use, the outcome, especially the morbidity and mortality, consistently increased as the severity of AKI increased. And they also found that the interstage agreement, the staging agreement between these criteria was not very bad. It ranged between 76% to up to 92%, suggesting that KDIGO could be used instead of the other two criteria. Now, the fundamental thread that goes through all these criteria is that the definition or a diagnosis of AKI is still anchored to a time-dependent change in serum creatinine or urine output. And I've just simplified it for the residents that this is what we need to diagnose AKI, either an absolute change or a relative change, but notice the duration in which the change needs to happen. So considering that it is anchored to serum creatinine and urine output, invariably there is limitations to definition, especially because we know that serum creatinine is not a very sensitive marker of kidney injury, and these has been mostly tested in ICU or tertiary hospital settings. It could lead to a potential misclassification in situation because there are many factors that can influence the serum creatinine level, some of which I have listed here. And more importantly, it does not give you any idea of the cause, because a creatinine of 5 in a severe dehydration secondary to diarrhea is very different from a 5 creatinine of a child with sepsis with multi-organ dysfunction, although both are classified maybe by the KDIGO to be in a similar stage, but their outcome, their trajectory is completely different, and it does not give you that sense. And from the patient point of view, because of these limitations, it remained of a moderate utility. And we can't use this criteria in the first 48 hours after birth in neonates. The challenge with urine output was that maybe in sick patients we monitor by putting a urinary catheter, but in patients who are admitted in wards in the community, it will be difficult, especially in young infants and children, to calculate accurately. And it may not be useful in specific clinical contexts. We know nephrotic syndrome, one of the cardinal clinical presentation may be oliguria, but not necessarily they have AKI. Similarly, a lot of AKIs may be non-oliguric, especially with nephrotoxic medications, patients on diuretics, or having acute tubular interstitial nephritis, which may be leading to. So we need to exercise some clinical judgment when we are using these definitions. Now I'll highlight 3 important limitations. One is that the factors which affect serum creatinine, which could be classified as an acute or a chronic effect, right from diet, the way you estimate the creatinine in the lab, and also the generation of creatinine, which may be high in some hypercatabolic states such as rhabdomyolysis, which may be low in some other states like sepsis all can influence serum creatinine level. And there are other chronic effects, which includes the effect of bilirubin, effect of malnutrition, and so on. So these needs to be kept in. And one of us, especially in an Indian setting, a challenge to use this is we hardly have a baseline creatinine on these children. Most of them are coming for the first time. Even if they have sick, many of them do not get a serum creatinine done as a part of their routine evaluation. That becomes a very major challenge in our setting to use this correctly. And they have given more than 10 ways how you try to overcome this barrier of not having a baseline creatinine. I'm not going through all this, but I just want to mention that the best correlation with the actual baseline value has been found if you have any value of baseline between -7 to up to 1 year. You could use that as a baseline value, and you can see here they have quite a moderate correlation with an actual baseline value. Then that's probably a suggestion. The other way, what we have done practically is assume that they have a normal GFR and calculate the serum creatinine from that, because modified GFR is serum creatinine into 0.413 into height by serum creatinine. So you solve for serum creatinine and try to put that value. You could also use normal reference changes, but reference values, but we don't have in an Indian population. We have done that exercise using the CNNS data that's just getting accepted in a publication, where we have looked at the serum creatinine range in over 15,000 children and tried to arrange at a normal range in an Indian context. The third is the biological and analytical variability. Its magnitude of change of 0.3 is small. Suppose you have a neonate with a 0.2 creatinine, and I say that 50% rise is AKI. It means that the creatinine becomes only 0.3. Now, that could be because of analytical or biological variability. And you can see here an absolute serum creatinine change of 0.3, which is one of the Akin criteria. You can see when you have a baseline of 1, 2, 3, 4, you can see that the rise is probably varies from 30% from the baseline to just 5 or 6% from the baseline. And that really brings in that question that how much is it of the biological or analytical contributing being factored here. So in this, the Chinese group came up with the concept which is used in other laboratory analytes, the concept of reference change value, which indicates that the value by which two serial results, here you are doing it 48 hours in interval, must differ to be considered statistically significant. That is, they're accounting for that biological variation above which the variation they take in to know whether there's an absolute change of 0.3 or more. And they showed in a large data they derived this reference change value and implemented it in another independent cohort and found that that it decreases the incidence of AKI, but the morbidity and outcome measures were just as similar to when you use the usual KDIGO criteria. So we tried to do something similar in our own group. So this was one of our residents' theses. So we tried to understand whether that we can apply in an Indian setting, because the biological variability can vary between population. So we derived this reference change value from a derivation cohort of around 400 children spread across 1 year to 17 years. We didn't get enough in the 18-year age group. We derived this RCV. We corrected that serum creatinine to that particular RCV for that age, and then applied it. What we called it as KDIGO RCV, or the P-ROC. And when we compared, there was a definite drastic drop in the incidence of AKI from around 42% to around 26 or 28%. But there was no change in the morbidity or mortality compared to no AKI when you used either of these criteria. But considering the significant drop, when we further looked at did some more analysis, we found that this adjusting to the reference change value, not surprisingly, misses those milder forms of AKI. So that becomes a concern when we start adjusting for these biological variability, and this probably needs to be validated in larger cohort. So although we have a very standardized definition which has been recalibrated over the years, the conundrum in AKI remains in terms of what is AKI, how do we diagnose it, and there are gaps which needs to be addressed, which has been brought up by the KDIGO in their document statement published a year back. So we are expecting the new guidelines to come up in a year or two, and they'll be trying to address many of these questions that that we also think about. Like, for example, should we make a difference between absolute change and a relative rise? How should the baseline, which is the best way to assess the baseline if they don't have one? How should the confounding non-kidney factors and also condition like fluid overload be considered within this approach of diagnosis and staging? Should the urine output be based on actual observed, measured, or an ideal body weight? And how will urine output be combined? How should it be combined with serum creatinine to get the best result? And of course, integration of the biomarkers. Which one of these would be the best? So, but nevertheless, this standardization helped us get a clear idea of the burden of the disease, and that's what I'm going to do in the next probably a minute. It made us realize that AKI exists everywhere. It's quite common, especially in those who are critically ill, and is an independent predictor of mortality. As you can see in this combined analysis of 94 large studies involving children, you can see that 1 in 5 children to 1 in 3 children in the ICU have some form of AKI. Around 10% receives dialysis. And what you notice is that consistently in most of them, there is a high mortality, but that mortality is higher in low middle income and low income countries, where the odds of dying is 4 times higher as compared to those without AKI. And this mortality rate is much higher if the child is receiving dialysis. And there is a difference in the mortality between an hospital-acquired AKI or a community-acquired AKI. But clearly, it just helped us understand the magnitude of the problem and the poor outcome if a child has AKI. The other thing that using the standard criteria, what came up was that AKI is often multifactorial. There are a list of reasons why a child can have AKI. When we looked at an Indian data, we looked at 3 published data of 3 large centers. As you can see here, the proportion more or less is what is reflected in the global series, with a little higher incidence in our group. But infection was the predominant etiology of AKI. Roughly 20 to 30%, 15 to 30% required some form of dialysis. The mortality in those receiving dialysis was much higher, as shown in the other global data. And what is very important is at the end of hospital discharge, a significant proportion has not completely recovered the kidney function, which means that these kids needs to be followed up over long term. So this brings in the concept of that probably the epidemiological thing of acute kidney injury may be different between a high income and a low middle income or low income community. Like, for example, the global snapshot survey done in 2016 showed that 80% of the AKI in community is community acquired in low income and low middle income countries. So although we have a better understanding, the knowledge gap still exists, especially regarding community acquired AKI in non-critically ill children, especially those who are admitted in the wards or in the community peripheral centers. And the data is largely driven by the epidemiological data is largely driven by high-income countries. Thank you.
So I have a timer on, so I'm gonna try my best to stick on the time. I know you're anxious for this day to end on time. So Rajiv asked me to talk about changing the paradigm in septic AKI. So these are my disclosures, but please be noticed that I did critical care nephrology fellowship in Cincinnati Children's, and this was sponsored by Baxter. I'm gonna try my best not to be biased to any of the commercial products here. So here's what I'm gonna talk about in the next 19 minutes. I'm going to just quickly reviewing the definitions of sepsis-induced acute kidney injury and how we can change the paradigm of managing acute kidney injury, and then talking briefly about the current immunomodulation devices that we have between our hands to change that paradigm. So I would start with this slide and remind you that it is hard to die without acute kidney injury in the ICU. So this is a graph, the survival graph for the AWARE study that we done back in 2017 that showed the mortality goes up with increased the severity of acute kidney injury, and this looks similar survival rate in adults with the sepsis, with the septic shock. And you can see here that 27% of adults dies if they develop acute kidney injury and sepsis. So what is sepsis-associated AKI? It looks simple. It is sepsis plus AKI. Okay, so two problems. However, as you heard from Dr. Anil before my presentation, there are a lot of definitions of acute kidney injury. For example, this 2020 article, systematic review in 2020, that's 8 years after the KDIGO comes up, people still found 4 definitions for sepsis, 3 definitions for acute kidney injury, a mismatch between what's sepsis and what's sepsis shot. So still the standardization of the sepsis-associated AKI has not been well established. So to respond to this problem, the ADKI, Acute Disease Quality Initiative, came up to unify that definition. Okay, so the first part is the sepsis, and they adopted the third international consensus definition for sepsis and septic shock using SOFA score to define the severity of sepsis. So that's the definition of sepsis they acquired. And you heard about the KDIGO 2012. So with that, sepsis-associated AKI is AKI plus sepsis. However, to be specific, in that ADKI consensus, they defined 2 different terms. The first one is sepsis-induced acute kidney injury, and this is just to to make the researchers aware of the close association between the sepsis as an incident by itself and the developing acute kidney injury. And they separated from sepsis-associated acute kidney injury. This acute kidney injury might not be related to the sepsis itself. It might be related, for example, for the hypotension, for the medication, for the contrast. So they emphasized on differentiating between sepsis-induced and sepsis-associated acute kidney injury. So changing the paradigm, I think wherever somebody talks about sepsis, acute kidney injury, you're gonna see this graph. Okay, this is made by ADKI, and whenever sepsis happens, there is PAMS and DAMS, pathogen-associated molecular patterns and damage-associated molecular patterns. The patterns or molecular patterns that comes from the pathogen or from the host. And this caused the activation of multiple systems in the body, and depends on what's the system, you're gonna end up having endotypes. And those endotypes will give you the phenotype of the sepsis-associated acute kidney injury. So to change the paradigm and what currently can do to change our management of sepsis-associated acute kidney injury, we can tackle any of these systems. So for example, talking about the microcirculation alterations in the kidney. So I want just to remind you that renal perfusion pressure is the mean arterial pressure minus the central venous pressure. And fluid overload will reduce renal perfusion, and intra-abdominal pressure may increase outflow pressure above the CVP. Keep in mind, whenever we resuscitate patients with sepsis, that the purpose of fluid resuscitation is to optimize preload, and beyond this, the fluids are only harmful. Now, to improve the microcirculation, currently the AKI community, they will tell you norepinephrine is the first line for to increase the blood pressure. Dopamine, the problem with dopamine is to increase cardiac, this might increase cardiac dysarrhythmias. Phenylephrine, it lacks the beta and adrenergic effect, so it's gonna cause high mortality. Vasopressin, they showed no big advantage over the norepinephrine. However, currently there is a great focus on the angiotensin II, and this is one of the things that you might consider for the future for managing sepsis-associated acute kidney injury. So here is the pathophysiology behind it. You all know that in normal conditions, you all know that in normal conditions, angiotensin should be cleaved to angiotensin 1 by the renin, and then by the ACE, it's converted to angiotensin 2. However, what happens in patients with septic shock, there is significant endothelial injury that will stop the ACE from converting angiotensin 1 to angiotensin 2. So the patients with sepsis, with vasopressin-resistant septic shock, they might be deficient for angiotensin 2 because there is no good conversion in angiotensin 1. And this has been known and published in 2023 in this 72 children cohort in multi-center observational study that showed up to 70% of patients or children with septic shock, they have deficiency in angiotensin 2. So there is a big study published in the Journal of Medicine called the ATHOS study, where they studied the angiotensin effect in patients with septic shock. And in that study, they concluded angiotensin can decrease the mortality and decrease the stay in the ICU for adults. They did post hoc analysis in that ATHOS study in terms for patients who required renal replacement therapy. And what they found that patients treated with angiotensin 2 had better 28-day survival rates. Those patients received renal replacement therapy, and they're more likely to be liberalized from renal replacement therapy. However, this is a small study, only 60 and to 45, and there's currently a clinical trial called ASCET trial that tests the impact of angiotensin 2 on acute kidney injury. There is a small study in children, and only 23 children that tested, or like they retrospectively looked at the effect of angiotensin 2 in improving the MAPS and the total equivalent doses of catecholamines. They saw a kind of nice signal. However, no clear observation for mortality or AKI recovery was observed, and likely this is because of the small number of patients. Now, another pathway that we can look into how we can change the management of septic AKI is how to manage the inflammation. And this is all the time questions about steroids. It is not so novel a treatment for sepsis-associated acute kidney injury. The biggest data we have regarding the efficacy of steroids in sepsis septic patients came from the adrenal trial. This is adult study, 3,800 patients with sepsis ventilated on pressors, and they were treated with 200 milligrams of hydrocortisone. What they found, they didn't find a good survival outcomes. Both arms were equal in terms of mortality. However, they found that patients who got treated with corticosteroid had earlier resolution of shock and less days of ventilation. This year, in 2025, there was a post hoc analysis for this a trial that was done in 2018, and this got published in JAMA. And what they looked is what's the renal replacement requirement following randomization with the steroids. And you can tell from here in both univariate and multivariate analysis, you can tell that the incidence of patients requiring renal replacement therapy who received corticosteroids were a little bit less than the placebo. So 21 versus 24%. So this is, mild decrease in incidence. It was statistically significant. However, what I say that maybe administering steroids for those patients is not, a big decision that you can take. It's available, so this might add some benefit to our patients. So the third pathway that we can hit is immunomodulation. And here it comes the role of extracorporeal therapies in patients with sepsis-induced acute kidney injury. The rationale of the extracorporeal therapies is that they might attenuate the immune response by reducing the circulating levels of cytokines and the triggers that can potentiate the responses, like endotoxins, PAMPs, DAMPs, and that this is to achieve immune balance and hemostasis. Currently, there are 4 recognized extracorporeal therapies for those patients. It's going to be, these are either hemoperfusion or hemofiltration or hemoadsorption or plasma exchange. I'm going to try to pass quickly on each of them. So what is the most recent guidelines from the Surviving Sepsis campaign that got published in 2021 says about those extracorporeal therapies? Let's say what they say. They said that for adults with sepsis or septic shock, we suggest against using polymyxin B hemoperfusion, which we're going to talk about, because there is low quality of evidence regarding this specific column. Okay, and they made no comment on the other filters. And again, this was in 2021, and they said we don't have enough evidence. We cannot say yes. We cannot say no for those columns. However, it seems that the critical care medicine community was not in agreement with these statements. So in 2023, Mehta and his group, they started to rephrase or like change the paradigm of septic AKI. And they went through all what is needed in terms of pressors and antibiotics. And they, at the end, they put here a consideration to start any of these ECT or extracorporeal therapy supports within 24 hours of the sepsis development, and they put it as a consideration. So they want to make the community think about the possible benefit of these devices. So let's talk about these devices in quick. The first one that came is the high volume hemofiltration. And what people will do is to start patients on CRRT, however, with double to triple the usual dose of CRRT, or they will do intermittent hemodialysis for 8 to 8 hours, and this is followed by conventional CRRT and AKI doses. Unfortunately, this data was not encouraging to carry on, or the primary data in this, in terms of this approach, hasn't been so encouraging. So then there is a kind of therapy, it's the hemoadsorption therapy, which is a technique where the sorbent are placed in direct contact with the blood via the extracellular circuit to remove toxins and inflammatory mediators. And one of these is the well-known CytoSorb column. If you look to the biologic or physiologic data that comes after treating patients with CytoSorb, you're going to see it is the heaven of the intensivist. It decreased the catecholamine requirements, it decreased the inflammatory markers, the white blood count, the procalcitonin, CRP, bilirubin, SOFA score, myoglobin. So it's like the heaven. That's what every critical care physician will suffer in his patients to improve the care of the child. So, however, when we look into these data, we don't see anything to support mortality. So these are the listed studies about the CytoSorb. Most of them are retrospective. One of them only is prospective. And what they found from this systematic analysis, those therapies do not, like CytoSorb in specific, do not improve mortality. So what's the problem here? We see good signals in terms of the labs and the clinical status of the patient, but the mortality is still the same. So do they work or they don't work? Here what comes the idea of precision medicine. The problem with all of those, the studies that came in, that they're applied blindly to all patients with septic shock, without looking into consideration what is the cohort of patients that they might get benefit of these therapies. So that's why there is something called CytoSorb score system, that you have to score the patient to see if the patient is candidate. There is the idea of starting those therapies in very early to get the benefit. And now there is good efforts to direct the initiation of these therapies based on the proteomic or genomics of the patients to evaluate what exactly the endotype that's happening inside that patient that make him or her candidate to receive such therapies. Apparently, there is a good market going for those therapies. A lot of companies are investing in those columns in Japan, USA, China. This is the Toramexin column, the one that I just told you about. And this is one of the earliest devices that was created to help patients with septic shock. So the principle is very easy. It's a column with fiber, and they mix and they engineer the column in a way that they stick polymyxin, which is a toxic antibiotics, but very effective antibiotics, to those fiber so they can absorb the endotoxins. So the first trial came in 2009. And this was a European trial, and they found improved mortality. However, two following trials showed no difference in mortality. And this is, again, tells us that the trials were not designed in a way to improve to select the good patients. Because when they look to the endotoxin assay, for those patients who have high endotoxin assay, the mortality was better. So this is a kind of precision medicine. The famous Oxyrius filter, this is from Baxter. We learned a lot about this during the COVID area. What's interesting that the Oxyrius filter showed similar endotoxin absorption like the Toramexin, and it showed similar absorption to the Cytosorb. So, and those machines are commonly available. However, till this moment, there are two currently published in 2025 trials where they studied the efficacy of these filters in patients with cardiac shock, and the results were not encouraging. And currently, there is a trial going for patients in septic shock. TAMOF is one of the big indications for plasma exchange. The idea here is patients presenting with thrombocytopenia associated multi-organ failure, they have deficiency of in Adams the TS13. So the idea of doing plasma exchange is to replace the Adams TS13. And this is a data came from 9 PICU centers in the US that showed that the patients with TAMOF who received TPE experienced less mortality rate than those who don't receive. And you can see here TPE was independent factor to predict mortality, favor mortality in those patients, and it is as you know, the predictivity was as good as the utilizing extracorporeal therapies. So my last slide here is about this selective cytopheretic device. The difference in this device is this has effect on So this has an effect on the freezing the activated white blood cells. So you can see here from the picture that how the white blood cells will stick outside the column. So they found their way out of the column and stick outside, and this will induce apoptosis in the white blood cells and decrease the inflammation. Just yesterday, there was a report in KI reports about using those filters in septic patients in the WeRock cohort. And this is the first time we have a data in children how those filters can reduce the mortality. With that, the time is off, and I'll stop right here. Thank you so much.
I'm very sorry for the glitch earlier. Just disclose that I'm just a financially stable nephrologist, but by no means a wealthy nephrologist, as Rajiv alleged, and the MAC was done. gifted by my wealthy sibling. So, yeah. So I'm very happy to talk about this topic on neonatal AKI and whether it's a new ball game compared to pediatric AKI. And just quickly go through some of the trends and causes in neonatal AKI. How do we diagnose it currently, and could we do better with newer tools and risk stratification modalities, and also how we treat neonatal AKI. So the pediatric definitions, we've gone through this multiple times today, from the classic ARF, which was renal failure. We changed the terminology to include injury, which would indicate damage much before a failure stage. And uniformly across all these definitions, we thought that the increasing stages meant more mortality, increasing length of hospital stay, and all were based on urine output and serum creatinine. So in neonatal AKI, it's more of the same. These are excellent for epidemiology studies. They have uniform definitions for us. They're quantifiable, measurable outcomes, and also it helped us to identify risk factors for neonatal AKI. So the urine output criteria is slightly different for neonatal AKI because we understand that the urine concentration ability of neonates are a little bit lesser. So we have a higher urine output category. And then also the reference creatinine for an AKI stage 3 is not 4 milligrams, but 2.5 milligrams. So this criteria was used in the AWAKEN-1 trial, and this showed a 30% incidence of AKI using this criteria. And neonates with AKI had a 4.6 times higher mortality compared with neonates with no AKI. It was 9.7% versus 1.4 in patients without AKI. And of course, the length of hospital stay was increased in babies who had AKI. Across neonatal populations, of course, if you subtype them or subgroup them, the incidence of AKI is quite higher in certain categories of babies who have, especially the highest ones are in the patients who receive extracorporeal membrane oxygenation by nature of the diseases that they have. And also perinatal asphyxia remains one of the commonest causes of neonatal admissions in India, and also one of the higher risk for developing an AKI. Necrotizing enterocolitis and also post-cardiac surgery are again important subgroups of patients who will have a higher incidence of AKI rather than compared to the 30% that we see in the general population of neonatal AKI. So this AWAKEN trial has now been extended into an AWAKEN-2, where the AWAKEN-1 had no prospective follow-up after discharge. So this includes a retrospective follow-up from a cohort who were born in the first 3 months of 2019. So now they are being followed up till 2025. So we know what happens to these babies as well in the long term. Coming on to risk factors for neonatal AKI, there are many traditional risk factors compared to maternal risk factors, which are hypertension, chorioamnionitis, maternal nephrotoxic medications, maternal CKD, and certain perinatal factors around birth. The high-risk populations are preterm and low birth weight, wherein the AWAKEN study also showed a very high incidence of AKI in patients, in babies who are born between gestational age 22 to 29 weeks compared to the other gestational ages. Having congenital heart disease, having a congenital anomaly of the kidney and the urinary tract, again, are high risk. But again, here in India, I think we have the problem of both plenty and less. So we have a mix of both developed and developing world problems. We now have poor maternal nutrition has hardly been addressed, but we have a lot of assisted reproductive technologies. Our NICUs are filled with preterm babies and low birth weight babies now. And also we are able to give advanced cardiopulmonary support for many of our babies, which was not probably seen in the last 10, 20 years back. So the type of AKI and the intensity of AKI that we see in our neonatal ICUs are rapidly changing as well. So a bit about neonatal renal physiology and why we should think a little bit different from pediatric AKI is the nephrogenesis begins from the 5th and continues almost till the 36th week. So if you're born very premature, you're going to have a low nephron mass and also have implications for future chronic kidney disease. There's significant changes in the renal blood flow at birth, where at birth you might have up to 5% of your cardiac output given to the kidneys, and in an adult it's almost 20 to 25%. And this is continuously changing as the baby grows. And this is also due to some increased systemic vascular resistance, but decreased renal vascular resistance. It's driven by angiotensin II and prostaglandins. So the urinary concentrating ability is again lower in neonates compared to adults. And this is also because of some ADH resistance inherently that is there in the neonatal kidney, and also because of pure solute gradients and also interference of prostaglandins. And the sodium reabsorption, if you see, is slightly lower in the neonates, so they might be losing more sodium in the urine compared to your normal infants. So the fractional excretion of sodium interpretation can also differ in neonates. So you need a higher cutoff of FeNA to tell between a pre-renal and a intrinsic AKI. So the GFR development, again, if you see, if you're born very preterm, your GFR ranges between 13 to 26 ml, whereas in a term infant, it's less than 13 ml, but in a term infant, it reaches around 26. And in a term infant, by 2 weeks, they reach around 54 ml. But in a preterm infant, by 2 weeks, they are only reach between 16 to 28. So using same definitions for preterm babies and for term infants are probably not the correct way to go. And if you see here in this cartoon here, you might see that babies who are born very premature, 28 to 32 weeks, they actually do not have a fall in creatinine like in the other subsets. They can actually have an increase in creatinine and a very delayed fall in the serum creatinine, even when they do not have kidney injury. So in neonatal AKI, when we are using the modified KDIGO definition, which is the best as of now that we have, are we using these definitions validly? Are these definitions really valid? Would serum creatinine be accurate in the face of rapidly changing kidney function? The maternal influence, how long does it last, whether it's 48 hours or even extends in the first postnatal week? In a preterm who has a high creatinine and reaches the NADID by 2 to 4 weeks, would we presume that they have AKI or not? Again, the urine output, we do have many babies having non-oliguric AKI. So whether our urine output criteria is valid in them, what is oliguria in neonates? Different studies have used even cutoffs like 2 ml per kilogram, and also especially in preterm infants. And urinary collection, again, is a really, really practical problem in the neonatal ICU. Not every ICU is prepared or equipped with manpower to have catheterization and use diaper weights and all that. So the utility in renal recovery, just having a normal creatinine, is it going to be enough? Or having a normal urine output, is it going to be enough? Can we call the babies have completely recovered from AKI? Probably not. And also with the current definitions, is there anything that we could do better using just creatinine and urine output? These are many studies which have looked at certain things like, could we have gestational age specific unique serum creatinine rise cutoff? So now we have a cutoff of 0.3 from a known baseline or a previous existing baseline. Is 0.3 an abrupt cutoff or an easy cutoff, or should we use a percentage rise in creatinine rather in based on gestational age? The rate of serum creatinine decline was described by Gupta. It's now called the Gupta method. Should that be seen as a persistent of AKI? A very slow fall in creatinine, can that be an indicator of a baby having ongoing kidney injury? And also, do we need new urine output criteria for gestational age between 24 to 29 weeks? And all these are probable things that we could think about using these current definitions or these two markers like creatinine and urine output. So ideally, we would like to intervene. Currently, we are intervening here when the GFR is already low, as defined by KDIGO criteria. But we would like to interfere here, or at least interfere here, when there is increased risk. And we do have some markers like the urinary NGAL or KIM1, which could predict the damage a bit earlier if we are able to apply it to at-risk neonates or infants. So our strategy for intervening before a significant kidney event like an AKI happening should be to probably identify patients at risk who get nephrotoxic medications, undergo imaging procedures which use nephrotoxic agents, undergoing surgery, or by definition very sick because of other risk scores, and then apply this kidney health assessment in them. So that would require medication adjustment, minimizing the current exposures of whatever sickness levels they have, and also inform the team to monitor them more carefully and have a watch on them. In the neonatal ICU, there are a lot of risk scores that are already being used. Some of them have relevance to organ injury as well, rather than just predicting the sickness level. They also have, one of that is the CRIB and the SNAPI score, which have good prediction of organ injury like AKI. So those ones can be applied or assumed to be having babies with these higher scores can be assumed to have higher risk of AKI. And also kidney injury specific, we know the RAI that's been applied in pediatric ICUs, the STAR scores, the Baby Ninja, and certain fluid overload studies can be used in the neonatal population. So this RAI is nothing like a cardiac troponin, which would tell us the need to do a biomarker or a test like a coronary angiogram. So we use it like patients who have a higher RAI would go on to require a biomarker testing to predict early kidney damage before the serum creatinine goes up. Can we do something like that in the neonatal ICU? The STAR score looked at not biomarkers, but it used 9 clinical and 1 lab, which is the serum creatinine. It looked at those parameters and was able to give a predictive score of, if you have a score of more than 31.5, it predicts a risk of AKI, and more than 59, it predicts severe AKI, and also predicted the need for dialysis in these patients. The baby Ninja is one. It's similar to the Ninja, where it looked at nephrotoxic medication use, both IV aminoglycosides and other medications, and they looked at both the compliance and the rate of AKI in the sustainability era, and both had better outcomes there. So this is again one thing that we can employ even without the electronic health record. In some of our institutes, we still do not have the capture of medications in the electronic health record. This is our pediatric data from our center. We did this manually using only the lab values from the electronic health record, but this is the pediatric non-critical ward patients who had a higher incidence of nephrotoxic medication use, but very poor creatinine monitoring. If you see, only 5.35% of our patients had adequate renal function monitoring, which we defined as having at least 2 creatinine in a period of 48 to 72 hours. And of patients who had nephrotoxic medication load, which was higher, which was very high, even in them, only 12% of them had a serum creatinine done in them. So our monitoring methods is still very, very poor. That is something that we have to loot. And of course, if you see, the PPI use and aminoglycoside use is quite high in our center, and I'm sure it's seen in other centers too. So other than that, moving on to biomarkers, we have discussed quite a lot about biomarkers in the previous session, so I'm going to skip a lot of these slides. So urinary NGAL. So using these clinical risk prediction scores along with biomarkers, does it improve your ability to treat a patient, identify a patient with higher risk of AKI, or treat them or decide for dialysis? This has been shown in the trial Focus 2 trial, where they combined the renal angina index to decide whether the baby needs a urinary NGAL assessment, and also use the fluid overload criteria to decide whether the baby would require a CRRT in the future. So something like that can also be given off to extended to the neonatal ICUs. But do we have excellent cutoffs like we have for the pediatric population for neonatal AKI yet? So there are different studies that have looked at cutoffs for urinary NGAL. So in this first study, the cutoff was more than 250, which predicts the AKI, which had a good area under the curve, especially in patients with severe HIE. The Indian studies, we have the median NGAL from JIPMA was 134.45 and 300 and 400 for different AKI stages respectively. And also an 86 and 86.8 nanogram per ml had a good sensitivity and specificity in predicting overall AKI. So this is an Indian study that we have. In the Baby Ninja cohort, they found a good negative predictive value of a urinary NGAL cutoff of more than 250. So these are some things that we have to fine tune and come out with our own cutoffs for, either electronic health alerts or the need for more monitoring in our babies. And also there are, again, evolving more urinary and serum biomarkers in the neonatal AKI group. And how are these biomarkers going to behave in preterm babies? Again, it's a question. The initial studies which have put out the traditional biomarkers like NGAL and KIM1 have found a similar utility in preterm infants, but these are very less studies, and you need more and more studies to see whether the same application of biomarkers could be done in preterm babies based on their gestational age. So are we there yet to talk about precision medicine in AKI? This paper attempted to classify neonatal AKI into phenotypes and subphenotypes using etiological, clinical, biochemical, and biomarker profiling. But I would honestly say we are still not there yet. We need more and more data to group these patients into phenotypes and then look at what's happening with these patients. So in the future or in the near future, I think our neonatal AKI diagnosis is going to look something like this, where we would apply a clinical risk score with or without a biomarker in patients who are at risk of AKI or have subclinical AKI, and then move on to having electronic alerts and do real-time prediction models and practically manage them better if we know that they are at risk. But it also simultaneously extrapolate all the data that we collect through the electronic health records and see if we can phenotype all these patients into certain subgroups, and then see if we can deliver patient-specific therapies. Moving on to briefly to neonatal AKI therapeutics. There's hardly many tools now for to a target drug or an individual drug that would reduce the incidence or prevent an AKI. So loop diuretics, where many of us use as a stress test, some of us would use to augment urine output and reduce fluid overload. It may help convert an ongoing AKI to a non-oliguric AKI, but by no means reduce the incidence or prevent an AKI. So KDIGO recommends a time-limited use of furosemide. Dopamine has no definitive studies which has demonstrated consistent effect. Theophylline and caffeine by means of adenosine antagonism have shown benefit. So there's a biological plausibility, and they've shown benefit in the subgroup with perinatal asphyxia. Phenoldiprem, which is again a dopamine agonist, again hasn't demonstrated any effect. So there's a very good review article by a systematic review by Girish here, so which really put out both in pediatrics and in neonatal AKI the utility of theophylline and aminophylline in preventing acute kidney injury. It's not treatment but prevention. And now KDIGO suggests that you can give a single dose of theophylline in neonates with severe perinatal asphyxia who are at risk of AKI to prevent an episode of AKI. So this is our own ongoing trial in AKI and aminophylline in our neonatal cohort. We have babies who are born more than 36 weeks of gestation and having a SNAPI score, which we did to, give an objective criteria for sickness in these neonates. And if you see the patient profile, 33%, and we're having perinatal asphyxia, and they also include a heterogeneous population of other conditions like sepsis, PPH in post-surgical cases, and all that. And we did have a quite high nephrotoxic medication use in our center, and this is across 3 centers, and uniformly all these centers use a lot of aminoglycosides. So we did not find any difference between the aminophylline group and the placebo group. So this is an interim analysis, it's not the full data. We did not find it. But when we use the delta urinary NGAL, we did find, although it's not significant yet, we found a better fall in the urinary NGAL in babies who had received aminophylline. We're hoping we can do some more subgroup analysis and see in which subgroups aminophylline would better suit, if is it only perinatal asphyxia, or there are other subgroups as well where this drug might benefit. Other than that, we talked about caffeine, which has a similar action like aminophylline, which has been studied and ongoing studies, especially in preterm infants where they're already being used for apnea of prematurity, whether that would prevent them from AKI and other problems. Also, erythropoietin and many other agents are being studied now. So, mentioning briefly about renal replacement therapy options, predominantly many of our ICUs use peritoneal dialysis. It's easy to set up, it's quick, it's cheaper, you have fluids available, and you don't need hardly any expertise to do that. So largely that is the standard practice in India currently. CRRT can be used in a selective patient population provided you have the expertise, you can establish a vascular access, and you have cost, which is, you can upfront accept the cost. It also has the better in terms of precision volume control, which might not be available in PD, and also give improved nutritional support, which might not be possible with just peritoneal dialysis. And there are 2 or 3 machines that would be suitable for neonates at this point: the CarpeDiem, the Aquadex, and the Nidus, of which the Nidus has very low blood volumes and can be used in very, very preterm infants. So these are some of the devices that none of these devices are in India, so I'm not going to go into detail. And CarpeDiem might come in the next couple of years here and might change the way that we treat neonatal AKI in our ICUs. Whether we shift many babies from peritoneal dialysis to CarpeDiem remains to be seen. So in summary, the incidence of neonatal AKI is high. It's especially high in certain subgroups, and it really reflects on the mortality as well. The tools for neonatal AKI, what we currently have, are useful, but they have their own flaws. So we can use these scores much better. We can use these tools much better. We can apply them regularly and keep our at-risk babies monitored more carefully. We can integrate EHR alerts and e-alerts when feasible into clinical practice, and also institute measures to mitigate risk of AKI in many of these babies. You do not have to have an AI prediction tool or anything. Even in your own center, you can attempt and sit with your pharmacy and sit with your administrators and do something about it. Use biomarkers and generate regional evidence for our own babies and our own patient phenotypes, and incorporation of precision phenotypes. Precision medicine would require these phenotypes, both clinical and biomarker signatures, in the future. Thank you.
And personally creating more sophisticated calcifications. But the problem, the challenge now our community is facing into the belief of the efficacy of the AI models is the absence of no randomized trials. That's what we all physicians are used to do. We should look to randomized clinical trials. And the data, most of the data is retrospective. But let me challenge you with this question. Does this really matter? And I'm going to show you how. This is a recent article this year in JSON. What they look to 4,800 articles. And those represents 3.8 million admissions, predicting acute kidney injury in such a huge number of cohort. And what they found, when they do verification for the accuracy of those models to predict acute kidney injury, and after validating those data internally and externally, they found amazing results. The AUC for prediction was about 0.82. Okay, so now tell me about any model, tell me about any clinical trial that you involve 3.8 million population and you verified it in 4,800 articles. So does it really matter to do a randomized control trial? So this is the question. I'm going to give you an example of how wonderful this will be in the future. So this work came from Mayo Clinic, and what they designed is a tree algorithm fed hour by hour by the patient's data through the electronic healthcare records. And they found, and they decided what are the endpoints. The endpoints is what is the ability of this AI model to predict acute kidney injury stage 3 lasting for more than 72 hours, or AKI leading to death in 48 hours, or kidney replacement therapy in 1 day, okay? So this is how the score will look. Patients get admitted, so the score will be 0. And dynamically, hour by hour, this AI will create a score, and that score will go up, up, up. And from time to time, when the specificity or sensitivity of this model to tell you, I am predicting AKI in the next 48 hours within that much assurance of sensitivity of 80% or specificity of 90%, the medical record system will give you an alert, okay? And this is how good the production model is. Have you heard about area the receiver operator curve of 97%? Okay, now you're gonna hear about the biomarkers in the next session, okay? And I challenge if any test can do as good as this AI model. So let's move to another topic, since we're talking about updates. Just quickly, you heard from Dr. Anil about AKI. I want just to remind you that AKI is not the story, the end of the story. There is something called AKD, okay? All AKIs are AKDs, acute kidney diseases. However, there are a lot of acute kidney diseases that cannot meet the definition of acute kidney injury. And why it is important, because if you look, we all, attracted to the AKI, okay? So in this Canadian population-based study in 1 million person, they found the incidence of AKI is 1.4%, and the incidence of AKD without AKI is almost 4 times that number. So this is very important to keep in mind. And why it matters? Because acute kidney disease without acute kidney injury is as bad as acute kidney injury. As you can see from this graph, you see here the blue line is the acute kidney disease without acute kidney injury, and you see that the cumulative mortality is as bad as the acute kidney injury. So, since we're talking about the updates, the new KDIGO for acute kidney injury is coming soon. In 2023, they called for revision of the 2012 acute kidney injury KDIGO criteria, and usually the work takes about 2 to 3 years to come up with these guidelines. So if you tell me what I am expecting to come out from this KDIGO guidelines, I will say the following, that the KDIGO will keep the same creatinine kinetics and urine output as foundational for diagnosis and staging of acute kidney injury. They will not get rid of that. We all know this. I think they're gonna keep the same thresholds. However, they're gonna emphasize on 2 concepts here. They're gonna emphasize on the function, and they're gonna emphasize on the damage. They will use the serum creatinine as a change and urine output as a markers for a change in the function, and they will emphasize on the new biomarkers as 1 or more urinary biomarkers to be added to that classification. So you all know about the stage 1, 2, 3. Okay, so this is 1, 2, 3 AKI, and each stage will be classified as biomarker negative or biomarker positive. Okay, and additionally, they will add another category of acute kidney injury that is no change in creatinine urine output. However, there's going to be a positive marker for injury. So this is what's I think is gonna change in the KDIGO. They wanna focus more on the recovery patterns of the acute kidney injury because till this minute, we don't have a good definitions for recovery of acute kidney injury. And maybe they will make recommendations to utilize cystatin C as a marker for function in addition to the creatinine. So now I'll move to the third part of my the presentation, is just to share with you some data or some questions that made me change my practice in the last couple of years. So this is now the question. If patients using RAS and they're coming into acute kidney injury or they're having surgery, do you stop or don't stop ACE inhibitors or ARBs? So this data came from JAMA last year, where they randomized patients going into non-cardiac surgeries, and they randomized them. Should we stop the ARBs or ACE versus continuing them? And you can see here that the incidence of acute kidney injury in both arms, using ACE or not using them, is almost the same. Okay. So what they found is only there is increased risk of hyperkalemia as expected, maybe intraoperative hypotension. So the idea here, maybe we can hold them for a couple of days after they recover from the surgery, and we can safely continue them. So how about the practice of holding ACE or ARBs after established acute kidney injury? So in this meta-analysis, in more than 70,000 patients in five studies, they evaluated what's the impact of holding ACE inhibitors on ARBs in patients after developing acute kidney injury. And you can see here that the mortality rate goes higher in patients who hold the ACE or ARBs inhibitors. And the kidney events, including acute kidney injury, were higher in the group that we hold the ACE inhibitors and ARBs inhibitors in them. So whatever we're afraid from by holding ACE inhibitor is just it's a myth. It seems that ACE inhibitors will prevent from further development of acute kidney injury or major kidney events such dialysis. And for sure, if you prescribe ACE or ARBs, you give a prescription for risk of hyperkalemia, and this is well reported here. So, in terms of practice change, I personally don't hold ACE inhibitors in patients presenting with acute kidney injury, because what I believe, the change that you see in the creatinine with those markers is functional, it's not damage. So how about SGLT2 inhibitors? These are drugs that are being utilized more and more in our population, mainly the adolescents. From the American Diabetes Association Professional Practice Committee, till this minute, they tell you, by 2022, they tell you until safety and effectiveness are established, SGLT2 inhibitors are not recommended for routine in-hospital use. So anybody who gets admitted for any reason in the hospital, you should hold those SGLT2 inhibitor. And this is the recommendation by 2022. Let's test if this is correct or not. So this is a trial, it's post-analysis trial of the Emperor Preserved and Reduced trial. Emperor trial is cardiovascular trial to evaluate the benefits of empagliflozin in patients with heart failure. Okay, so if you look to this graph, patients in that Emperor, the original study, started on SGLT inhibitors, is in the blue line, and those without SGLT inhibitor, they're in the red line. Okay, so you can see here that the estimated GFR goes down with the SGLT2. However, after 3 months, the two arms, they start from the same GFR. So it seems that change in estimated GFR in SGLT2 inhibitors group is temporary. It's a matter of time till the kidney regulates its hemodynamics. So in this study, here, they holded the SGLT2 inhibitor. So the arm that were taking the SGLT2 improve their GFR by about 3 to 4, okay? And this is the only benefit they got. However, those patients who holded the SGLT2 inhibitor, they got annualized risk of cardiovascular death with hazard ratio of 0.75, decreased functionality, worsening glucose control, increased body weight, increased BNP, increased uric acid, worsening, at the long term, they have worsening estimated GFR. So this is another signal for us that these inhibitors are not harmful in terms of acute kidney injury. And this is a big systematic analysis that looks on the efficacy of SGLT2 inhibitor on acute kidney injury in patients with chronic kidney disease, cardiovascular problems, and diabetes. And you can see that using SGLT2 inhibitor is favoring the protection of acute kidney injury. So that recommendations from 2022 by the American Society of Diabetes is not valid anymore. Another quick update is about the use of amino acids to prevent acute kidney injury. The rationale here is amino acids increase the nephron plasma flow by means of decreased afferent arterial resistance. They decrease the tubular glomerular feedback activation. They increase the cortical nitric oxide synthase activity. And the end result is probably the amino acids can improve the circulation in the kidney and prevent from acute kidney injury. And this statistically has been proven effective in this New England Journal of Medicine study that was published last year. In this study, 3,500 patients in 22 centers in 3 countries. And what they found, and the conclusion was, you can look to this table, that really there is a decrease in the risk of acute kidney injury in patients receiving IV amino acids. So, but if you look in details in this table, the reduction was mainly in the is stage 1 acute kidney injury, which is, clinically not that significant. There was no change in stage 2 acute kidney injury, and there is a good change in stage 3. However, if you look into this data more, to prevent any acute kidney injury, we have to treat 21. And if we want to prevent stage 3 acute kidney injury, we need to treat 72 patients with the IV amino acid. In addition to this data said that there was no difference in initiating dialysis, and most of the secondary outcomes that they have set for this study were similar between the two groups. So now this comes to a question. I know statistically improving, but you can tell that you have to treat a lot of patients to prevent one incident, and at the end, the utilization of dialysis was the same between groups. So I leave this to your judgment to think if this is useful to apply or not. Now, acute kidney injury in heart failure, and this is all the time a battle that we have as nephrologists with cardiologists. I don't know if there are cardiologists between the audience, but all the time we have this consultation. Patients presenting with congenital heart disease, and they're in heart failure, and they have 2 diureses. And then after that, the acute, they develop acute kidney injury, creatinine or acute kidney disease. Creatinine goes up, and we were consulted. So our first recommendation is to decrease the rate of diuresis to improve the kidney function. That's at least was my practice. So let's test this. So there is a trial that done, and unfortunately there are no data in children, but there is a trial called the ESCAPE trial, where it's an adult trial where they tested the outcome of pulmonary catheterization in patients with heart failure, and they did this study as a post-hoc analysis in this study. So this figure tells the whole story about the study. So they categorize the group into the patients into 4 groups. Those without congestion, so they got treated well with their heart failure, and without worsening renal failure, and this is the null value, okay? This is the best group. And then there is patients with worsening renal function plus congestion, no worsening renal function with congestion, and worsening renal function without congestion. And you can tell here, for this group, worsening renal function and congestion, the odds ratio of mortality was the highest. Look to the third group, worsening renal function, but with active diuresis, so there is no congestion, the risk of mortality is as good as the group without congestion and without worsening renal function. So this now comes to my mind. I said, okay, let the creatinine goes as much as it wants, but what matters is the congestion as long as the child is making good urine. Another piece of evidence, this is the dose trial. This is straightforward dose about the appropriate doses of diuretics in patients with heart failure, adults. And you look to this survival curve. The groups of patients are those with a stable renal failure, stable renal function, so no change in their creatinine after utilizing diuretics, and worsening renal function in the green, and the improvement in renal function. And look at this. So the group of improving renal function did the worse, okay? And this is again a sign that what matters in those patients is the decongestion itself, regardless of the creatinine, how it goes. Now, what's coming is a lot in terms of acute kidney injury. These are the registered studies. They will look into the biomarkers of applying different AKI care bundle. They're going to look into the dapagliflozin in terms of preventing acute kidney injury. Ravulizumab, a lot of studies in the border. However, I've been interested in acute kidney injury for more than 15 years, and I heard a lot of randomized clinical trial, And unfortunately, most of them will not come up with good impressions. Okay, so till this minute, we don't have an effective way to manage acute kidney injury. And is it now the time to revive the AKI trials? As I said in my previous presentation, there's a problem with the designs. We're not using the appropriate timing to evaluate our intervention. We're not using heterozygous, we're using most of the time heterogeneous population for our patients to do the intervention. And again, the endpoints should be changed. Mortality is not the only thing. Other things that we look into it is length of stay, ventilation, and recovery of the kidney. And with that, thank you so much.
Now the tea break.
So our next session is early versus late KRT initiation in pediatric AKI. Where do we stand? Speaker is Dr. Girish Bhatt sir, and may I request the chairpersons Dr. Shumantru Raut and Dr. Nandini Sinha Roy to please come up on stage. Dr. Shumantru Raut is he's associate professor in pediatric nephrology in North Bengal Medical College, Darjeeling, and consultant pediatric nephrologist in Neotia Bhagirathi Women and Child Care Center. And Dr. Nandini Sinha is consultant pediatrician in Noihati, West Bengal Health Service, and she's also a IAP ALS BLS faculty. And Dr. Girish Bhatt sir is Professor Division of Pediatric Nephrology in AIIMS Bhopal. He has his interests cover wide aspects like AKI, tubular disorder, childhood hypertension, evidence-based medicine, epidemiology, and meta-analysis. He has received numerous awards and honors, and also has numerable publications. So over to you, sir.
Thank you, Dr. Devlina, for the kind introduction. And thank you, Rajiv sir, for the kind invitation too. So in the next 18 to 20 minutes, I'll be covering what is our present evidence regarding the early or late initiation of the renal replacement therapy. So this has been covered. What is acute kidney injury? This has been covered. What is the incidence as well as the mortality of the AKI? This has been discussed. And what is point here important is that in the low-income countries, the mortality related to the acute kidney injury is quite high than as compared to the high-income countries. This is the KDIGO definition that has been covered, and this is the most commonly used definition because it is the only definition which incorporated the pediatric AKI in it, as well as there are some limitations of the serum creatinine which has been highlighted in the previous. So whenever there is a edema, we usually use the adjusted serum creatinine. The formula for the adjusted serum creatinine is shown in this slide. Okay. So now coming to the main topic, that is the AKI. So we have AKI in any patients. Patients are at risk of acute kidney injury. Okay. Then what we do? We reevaluate the risk of AKI if the patient is at risk, as well as we monitor the urine output, serum creatinine, correct hypovolemia if it is present, avoid nephrotoxic drugs. If the patient develops AKI, yes, then what we go? We investigate the etiology and treat the specific cause. If the patient develops stage AKI, then we evaluate the medications for the dose, as well as we evaluate and prepare for RRT. And this is here the question comes, the late or early renal replacement therapy. So the story starts in 1960 when some of the investigators, they investigated in 15 patients that whether the initiation of the prophylactic hemodialysis have any mortality benefit. So what they showed, this was not, they were not having a control group in this study, but they compared their experience with their previous experience, and they showed that the SD initiation based on the only urea decreased the mortality, which was significant. Now, what was their hypothesis why the early RRT benefited? So it was due to the improved in the fluid and electrolyte balances because of the removal of the toxins, as well as prevent other AKI associated complications. Also, there was some of the harm associated. What were these harms? Like obviously hypotension during the process, bleeding, infections, hypothermia, as well as arrhythmia. So we have to balance both of these. But the other question was, many of these patients, they recover spontaneously and there was no need of RRT. And here comes the role of conventional or the late renal replacement therapy. So this was the first trial that was conducted, I think it was in India in the 1997. It was a quasi-randomized trial, not a real randomized control trial, where the investigators, they took 35 cases with the acute tubular necrosis. Group A was have a conservative management, while Group B was early, and the total numbers were 18. And the criteria was if there was a decrease in the means urea was 120 milligram percentage, as well as the creatinine was less than 7 milligram per deciliter. So they showed that the mortality was lower in early group, that is about 22% in the early versus 29.4 in the late group, and the hospital stay was also lower. Then there was a number of trials that were conducted over the last 2 decades, and we can see that the trial by Baumann et al., then Elaine, then Ideal ICU, and the START AKI, and finally AKIKI 2. So these were the number of trials that were conducted, because obviously this topic was quite a debatable topic and we have not reached at the consensus. So we'll discuss some of these trials and what are the important points or take-home messages from these points. The first was the Elaine trial. So this Elaine trial was a single prospective randomized control trial that included a total of 231 patients. And the inclusion criteria here was the AKI with KDIGO 2 or KDIGO stage 3 and an NGAL cutoff of more than 150 nanogram per deciliter. But here the main point was that most of these patients were surgical patients. 88% of these cohort, they consist of the surgical patients, and 47% of these were having a cardiac diseases. So what they did the RRT initiation. They divided into 2 groups. The early strategy, where they have started the hemodialysis when the patients reached within 8 hours of the reaching KDIGO stage 2. In the second, that is in late, what they have done, they started the dialysis when the patients they reached KDIGO stage 3 within 12 hours of reaching KDIGO stage 3. This was the delayed strategy. So they compared the two. The primary outcome was the mortality, and you can see here that there was a significant difference in the mortality in this Elaine trial. The mortality in the delayed group was 54%, while in the early group it was 39.3%. There was also trends of significance in other outcomes, secondary outcomes like time in RRT, renal functions, as well as hospital stay. So this trial clearly showed that there is a benefit of starting early renal replacement therapy. But the limitations, what were the limitations of these? Most of these patients were surgical, so this trial was not a generalizable trial. There was a fragility index of 3. So what is the meaning of this fragility index? So if in early RRT, there would have been 3 more deaths or 3 fewer deaths in the delayed RRT, this p-value would have been non-significant. The first was 3. The second was, this was a single center trial. And we know that a single center trial, they have a lot of biases for sample size, as well as the publication bias, as well as the reporting biases. And early initiation was KDIGO stage 2, and just based on the creatinine and urea, we don't start renal replacement therapy. Then came the second trial, is the AKIKI trial. Now we look at what is it. So this was a multicentric unblinded open randomized control trial in 31 ICUs and with a total of 620 patients. So what was the criteria? The criteria was AKI KDIGO 3 with ATN, that is it was a ischemic or toxic injury, and the patient were on catecholamines, that is 80% of these patients were on catecholamines. So they have divided the early as well as the late strategy. So early was KDIGO stage 3 and the dialysis was started within 6 hours, and the delayed or the emergency was the second. These were the emergency indications of AKI. So in the early, what they have done, they have started the dialysis within 6 hours of KDIGO 3. In the late, they have only used the emergent criteria, and these were the emergent indications. What were these? Like severe hyperkalemia, metabolic acidosis, pulmonary edema, and a blood urea nitrogen level is higher than 112. So just remember that it is a BUN and not a urea. For urea, we have to multiply it by 2.1. Okay. Then oliguria for more than 72 hours after randomization, and the choice of RRT was on the discretion of the individual centers. So what they found? They found that there was no significant difference with respect to the mortality. The mortality was similar in both the groups. In the secondary outcomes, what they found that the patients in the late group, they can avoid approximately 49% in patients, they can avoid renal replacement therapy, which is having its own risk. But there were certain limitations. What were these limitations? These were the inclusion of patients with advanced kidney injury, as most of these patients were the inotropes, and over 50% of these patients, they received intermittent hemodialysis and on inotropes, because we know that if any patient is on inotropes, what we can go, we either go for a CRRT or PRRT in these subgroups. Now, another trial was the IDEAL ICU trial. This was also a multi-center controlled open label 2-group randomized control trial in 29 ICUs with a total of 488 patients. And here the criteria was AKI-F, rifle criteria, the F, the failure state with septic shock. So they have again divided into early as well as the late strategy. In the early strategy, what they have done, they have initiated dialysis within 12 hours of the F stage, and in the late, what they have done, they have started the dialysis after 48 hours of the F stage, and they have then compared the mortality in these two subgroups. So what they found that there was no significant difference. You can see it was 54% in one group and 58%, and the p-value was not significant. Then the another trial was the START AKI trial. The START AKI trial was again a multinational open label randomized control trial in 160 hospitals of 15 countries. And they have included the critically ill patients with the kidney dysfunction and severe AKI, that is KDIGO stage 2 or 3. So they have divided it into the two phases. The first is the accelerated. The accelerated means early, and the other is the delayed one or this accelerated. In this, what they have done dialysis for the emergent and persistent AKI for more than 72 hours. While in the accelerated, what they have done, in accelerated, they have started the KRT within 12 hours of KDIGO stage 2. So these were the differences in these trials. So what they found, that there was no significant difference as far as the mortality is concerned. You can see the risk ratio is just 1, no difference. But what was interesting in this trial was the patients who were given early RRT, accelerated form, the dialysis dependence was 70%. The risk ratio was 1.7. So they have 70% more dialysis dependence than as compared to the patients who were given late RRT or the conservative status. As well as other things like the adverse events that were quite common in cases of early initiation of RRT. So two things, dialysis dependent and adverse event in early RRT group. So this is a summary of large randomized control trials. You can see in the screen we have, these are multicentric and well conducted trials. So out of these, only one trial, that is the ELEN trial, has shown that there is a benefit of early initiation of renal replacement therapy. Okay. So since there was a evidence gap, we conducted a systematic review in 21. In 2017, we published a systematic review, but since 2 or 3 more trials were available, then we updated this in the 2021, and this was the search strategy which we have used, and we have identified 785 total articles, and finally total 14 articles were included in our data synthesis. Okay, so if we look at the characteristic of these trials, then you can see, so for the fellows, this is the risk of bias, ROB1 tool which we use for the bias in this study. So you can see if this is a green, it's a low risk. If it's this yellow, it's a unclear risk of bias, and this red is a high risk of bias. So you can see that the IDEAL ICU trial, it has a low risk of bias. AKI trial, it have a mixed one, that is unclear as well as the low risk of bias. START AKI, it has a low risk of bias, and this ELEN trial, it has some mixed, means unclear in 2 domains, while it was like low risk in other domains. Okay, so most of these trials were heterogeneous trials having low or high or unclear risk of bias, and this was the evidence synthesis. So these total 14 trials, all of these trials shows the mortality. So there was no benefit of mortality. You can see here this diamond, this pooled estimate is crossing this line of no effect. This is called as the line of no effect, and this is crossing the line of no effect. So there was no benefit of early RRT, especially with regard to the early initiation of renal replacement therapy. Again, we did for the dialysis dependence on day 19, and these trials showed that if the dialysis dependence on day 19 is higher in the cases of early renal replacement therapy, and the dialysis dependence was 55% in the early phases in the patients who underwent early dialysis. Similarly, the adverse event were quite common. You can see these are the adverse event. Adverse event like hypotension and hypophosphatemia was more common in the patients who underwent early initiation of hemodialysis. Okay. Now, what happened to these? Why these patients were dialysis dependent? So there is a concept of dialytrauma. So what is this dialytrauma? We know that whenever a patient is undergoing dialysis, there is a lot of changes, hemodynamic changes that are ongoing. For example, the patient has hypotension, the patient is undergoing electrolyte imbalances. As a result of which, there is a delay in the renal recovery. So these are, if we are going for an aggressive ultrafiltration, more intense dialysis, longer exposure to dialysis, more frequent dialysis, this delays the renal recovery, and this is the concept of the dialytrauma. Now, why were these trials heterogeneous? So we also did a subgroup analysis. Subgroup means the subgroup based on single center, because we have just discussed that the single center trials, they have inherited risk of biases. So when we did this subgroup analysis, so we found that all the multicentric trials, they were not showing any benefit in terms of mortality. So there was no benefit if it is a multicentric trial, and we know that the multicentric trials, they are more robust trial than as compared to the single center trial. While here you can say that the single center trial, they have shown a significance. So there is a bias. For just the fellows, how we narrate this diamond. So what we here this is the risk ratio, RR is 0.77. So 1 minus 0.77 is, it is 33%. So if we are doing early RRT, then the risk of AKI or the risk of mortality decreases by 33%. So this is how you interpret this diamond. Okay. So what they have shown that there is no difference in the mortality. We have also done the risk subgroup based on the risk of bias, high risk of bias versus low risk of bias, but there was no difference. We have also done a subgroup analysis based on the severity of the illness, whether based on the SOFA score, and there was no significant difference. Okay. We have also done the grade evidence. So whenever you are looking at a meta-analysis, just don't look at this forest plot. Always look at the grade evidence, because this grade evidence will let you know how certain you are into your effect estimate. Okay, so always look at the grade evidence. So here we have also done the grade evidence. So for the grade evidence, we have seen that in the overall day 30 mortality, we have a high grade, means high certainty of the grade. For 90-day mortality, we have also high. And for the dialysis, we have dialysis on the day, we have a moderate. So what is the meaning of this? So if the grade evidence or the certainty of the evidence is high, we are very confident that the true effect lies close to the effect estimate. Okay, and no further trials are likely to change our effect estimate. This is the meaning. If it is a moderate, so we are moderately confident, and the further trials may change. If we are low, it means we are not confident, and we need further more trials for these both downwards, low and very low. We are little confident into our effect estimate, and we will be needing further trials. But since it was quite high, means the overall day 30 mortality as well as 60-day and dialysis dependence was moderate, so we are quite confident in our estimate. Okay. So following this, individual patient data meta-analysis by the Gaudry group also showed that there is no difference. So what is the difference between an individual data meta-analysis and a conventional meta-analysis? So in the individual data meta-analysis, you take data from all of the authors and then pool. It's just a study. While in this conventional, you take data from which is available on the publication. So they have used the data from last 10 years from these 8 or 9 studies, and they also found that there is no benefit of early initiation of renal replacement therapy. Okay. So what was the main shortfalls in these trials? So the timing of RRT in various trials was quite variable. So if you look at the early, okay, in early it varied from 2 to 6 hours. There was quite a variation in the late stages, and it varied from 31 to as high as 57. So specifically, the timing was quite variable in these 3 or 4 trials. Okay. Now we have seen the first trial, the AKK, that we can delay the progression, or we can delay or we can wait for initiation of renal replacement therapy. But what time or what is the time through which we can wait for initiation of the renal replacement therapy? And this was This was given by the AKIKI 2. The answer to this question was given by AKIKI 2 trial. So what they did, this was again in 39 ICUs in the France open label randomized control trial. And here the inclusion criteria was AKI KDIGO stage 3 with oliguria for more than 72 hours and the blood urea nitrogen 112 milligram per deciliter. So they again divided into two groups. So delayed and more delayed. Okay, but because they want to know if we are deferring the RRT after 72 hours, what will happen to our patients? Is it beneficial? We will be able to avoid further RRT initiation. So what they found here in the this group, they have initiated RRT just after randomization, the delayed. In the more delayed, they have done RRT if there are urgent criteria or they have defined a BN, they have raised the BN to more than 25%, that is 140 milligram per deciliter for 1 day. In this setting, they have done the renal replacement therapy. So what they found that there was no difference in the primary outcome, and the primary outcome here was not the mortality but the RRT free days at day 19. But what they observed here in the secondary outcomes, that in cases of more delay, the mortality was slightly higher. It was 55% than as compared to 44% in the earlier group. And this was, the p-value was 0.07%, and it was not a borderline significant, but may become significant if the sample size has been taken according to this one. On day 30, the number of the hazard of death was also quite high, and it was 1.65 for the patients who were given delayed RRT beyond 72 hours. Okay. So these trials, what this trial AKIKI 2 have shown, that they have not utilized the fluid overload status or oliguria or anuria, which others they have utilized. And we know that whenever there is oliguria or anuria, there are more chances of hyperkalemia or electrolyte imbalances. So this, especially in the pediatric age group, we can see that if there is a high fluid overload, for example, the data has come from PCRRT registry, where they have shown that if the fluid overload is less than 10%, then there are 29.4% chances of mortality. If it is 10 to 20%, then their chances becomes 43%. And for more than 20% fluid overload, the chances become 65.6, which is quite high. Okay. And the adjusted mortality with fluid overload more than 20% was 8.5 times. So this was adjusted. They have adjusted for all other effects. So what they have shown, that clinically significant fluid overload is defined if it is more than or equal to 10%, and this is independently associated with an increased risk of mortality. A recent meta-analysis, they have also shown, this was published in the Lancet, and they have also shown that even the earlier fluid overload, if the fluid overload occurs during the initial 24 hours also, then this is also associated with a high mortality of approximately, you can see 7.93% to 8.77%. Also, regarding the fluid accumulation at RRT initiation, the risk of mortality, they have shown that a fluid overload of more than 10% and 20% in the RRT initiation, it causes increased mortality in the pediatric age group, and hence they stated that the clinician should contempt commencing RRT at these specific cutoff points. So we have an evidence-based cutoff point for fluid overload in the ICU, that if the fluid overload is above this, then we can initiate renal replacement therapy because it is associated with an adverse event. Okay. So last slide. So what are the learning points from these trial or applicability and redirectness? So we do not have trials in pediatric age group. We have trials in the adults, but recently one trial has been completed in the pediatric age group, and I think it will be published soon. So what we have seen, there is no benefit of initiation, early initiation of RRT. It delays the recovery as a result of dilate trauma, increased healthcare utilizations. We have still urgent indications like fluid accumulation, refractory to diuretic therapy or pulmonary edema, severe hyperkalemia, over manifestations of uremia, severe metabolic acidosis, and removal of the dialysable toxins. And how much to delay? There is a poorly defined threshold that likely varies between the patient to patient, and we have to consider patient to patient for initiation of the renal replacement therapy. And we have a question that till which point we can delay our renal replacement therapy in these conditions. Okay, so thank you. These are the reference articles. And I invite all the young faculties for this workshop at our institute. This is Saransh workshop. And the government of India is nowadays now developing an evidence-based guidelines through the DHR. So this is the registration is free for these, and will be have a selection for this particular workshop. Thank you.